All right. Good morning, good afternoon, good evening, depending from where you are connected. We are very happy to welcome you at this webinar on preventative vaccination of frontline workers and healthcare workers in Ebola at high-risk countries. I'm Aminata Bagayoko. I'm a medical doctor. I'm working at the viral hemorrhagic fever team at WHO HQ here in Geneva. So we would like to go through the housekeeping. And before we start, we would like you to know that this virtual training adheres to the code of conduct to prevent harassment, including sexual harassment at WHO event. And for the technical part, we'd like to remind you that if you want to ask any question on this webinar, please go to the Q&A section, as you can see here in this slide. But for any further question regarding the IT, please go to the chat. We have, this webinar is being interpreted in French, English, and Portuguese, depending from which language you speak. So please go to the caption part to interpret the webinar in French, English, or Portuguese. There is a live transcription. You can choose to show the captions or to hide it. And we'd like also to remind you that this webinar will be recording. So by staying here, we will have your consent. So the recording, the material and feedback, you will be available after this session. So as we continue to improve our training program, your feedback is invaluable to us. A survey will be shared at the end of the session, so we highly encourage you to share your thoughts and suggestions. Your input will help us tailor further session to better meet your needs and expectations. This is the agenda we are going through for this webinar, and I would like to invite Dr. Mori Keita, a regional advisor, infectious hazard preparedness at WHO Afro, for his welcome remark. So without further ado, Dr. Mori Keita, please proceed. I will stop sharing my screen.
Thank you so much, Aminata. Distinguished participant, ladies and gentlemen, a dear colleague, I'm pleased to welcome you to today's important webinar on preventative vaccination of frontline and healthcare workers in Ebola at-risk countries. I sincerely appreciate your participation and your commitment to learning more about risk mitigation strategies for better preparedness against this dangerous pathogen. I'm sure you will agree that the African region is increasingly vulnerable to epidemics, disasters, and public health emergencies that jeopardize global health security. This is surely true for Ebola. For example, between 2010 and 2022, so roughly over the past 10 years, a total of 29 outbreaks were reported. In the 10 years prior to that, there were only 15 outbreaks. In other words, there was an approximately doubling in the number of epidemics. These outbreaks have had a wide range of socio-economic consequences, including loss of life and the disruption of trade and travel. There has been some good news, though. In November 2019, WHO pre-qualified an Ebola vaccine for the first time. In December of the same year, the vaccine was approved by the FDA. In January 2021, Merck, the company, confirmed an agreement with UNICEF to establish the world's first global Ebola vaccine stockpile with available to support future Ebola vaccine epidemics. This vaccine was initially intended for use in epidemics, in response to epidemics, of course. But the Strategic Advisory Group of Experts on Immunization says now also recommend the use of the vaccine for frontline and healthcare workers preventatively in advance of an outbreak. There is, therefore, a general consensus on the importance of preventative vaccination in preparedness and response to epidemics. In turn, this underscores the need to promote communication and capacity building for these kind of interventions, including the sharing of best practices and lessons learned. That brings us to this webinar, which we hope can kickstart discussion on advocating and providing support for accelerating the implementation of this important intervention. To make it happen, country commitments are vital. If fully implemented and properly monitored and scaled up, preventative vaccination can make a real and tangible difference. Once again, I extend my warmest welcome to each and every one of you. Your attendance is a clear demonstration of your interest to advancing emergency preparedness in the WHO African region, and we are truly grateful. On behalf of Dr. Dick Chamla, the Emergency Preparedness Program Manager, and also myself, I wish you fruitful discussion. Thank you. Merci beaucoup. Obrigado.
Thank you, Maury. Thank you very much for this speech. And I will now turn to Dr. Charles Shea Bisionje. I hope he is there. He is the Regional Advisor on Vaccine Preventable Disease. Dr. Charles, please.
Merci beaucoup, Aminata. Merci, Maury. This is a very important webinar, as Dr. Keita has just indicated. Health workers are at an increased risk of vaccine-preventable diseases, affecting the health and safety of both health workers and their patients. Protecting health workers and ensuring occupational health safety is fundamental for well-functioning and resilient health systems. Vaccinated health workers are more likely to recommend vaccination to their patients and caregivers and to be advocates for immunization. And as you know, we also have some level of vaccine hesitancy among healthcare workers. So the ones who are vaccinated, they're more likely to be advocates in addition to being protected themselves. So vaccination for health workers is an important aspect of infection prevention and control and should be incorporated into comprehensive, gender-responsive programs for health workers, occupational health safety for health workers, in line with national immunization and occupational health safety policies and laws. Health workers are the backbone of any functioning and resilient healthcare system. Without health workers, health services simply cannot be delivered. As we know, vaccines are not just for children. As we shift our focus to vaccination across the life course, healthcare vaccination programs are an important step towards building adult vaccination programs and life course vaccination. As we progress towards COVID-19 vaccine integration, we can also be thinking about what other vaccines should be offered to our healthcare workers. For those countries at risk of Ebola outbreaks, Ebola vaccination offers countries a chance to improve preparedness and build these important adult vaccination programs. So this webinar is very important, and I thank all of you for attending. I thank the organizers, and I thank the presenters. So over to you.
Thank you, Dr. Charles. Thank you very much for this speech. And I would like to remind you, all the attendees, please, for the Q and R are for the technical questions. Please use the chat only for technical issue on the IT side. So now for the following 10 minutes, I would like to call Dr. Alejandro Javier Costa, scientist at the WHO HQ here in Geneva. Alejandro, over to you. Alejandro, can you hear us?
Thank you very much, Aminata. Can you see my screen?
Yes, I can see your screen.
Okay. Thank you very much, and good morning, good afternoon, and good evening to everybody. I will talk about the International Coordinated Group for Vaccine Provision, and in this particular case, about the Ebola vaccine. As it was introduced by Mori, this stockpile has been very important to respond to outbreaks in the latest outbreaks that we had in DRC. So just to give you a little background, I think most of you know very well the ICG mechanism, but in case that you are not aware, this mechanism has been created in 1997, and it was following a big epidemic in Nigeria of meningitis, Neisseria meningitis, and all countries in Africa asked WHO to create a mechanism to guarantee that the vaccine would be available. At that time, the vaccine was run out of the stock of the manufacturers, and it was a big crisis because there wasn't enough vaccine to stop the epidemic. So following this big epidemic of meningitis in Nigeria, there has been many attempts as well to create further stockpiles, and it was in 2001, that was created the yellow fever stockpile, and then cholera, and the last one is the Ebola stockpile that has been created in 2021. This stockpile was created because of the big epidemic that we had in West Africa, and following this big epidemic, there was another big epidemic in DRC from 2018 to 2020. So the vaccine has been pre-qualified in 2021, and then we immediately, the ICG, the partners of the ICG, decided to create the stockpile. So the members of the ICG are the International Red Cross Federation, MSF, Médecins Sans Frontières, UNICEF, and WHO. So the guiding principles for the ICG mechanism are, first of all, equity, because the vaccine would not be available for everybody if we have different countries following request or asking for the vaccine in the middle of an outbreak. So the distribution of the vaccine is based on the epidemiological situation. Of course, we need to have lab confirmed cases, and this is a public health emergency. So this is equity based on scientific data. It's not based on, for example, political reasons or economic influences. This is what we call independence. So this is something that all the decisions are made without having other criteria rather than the epidemiology and lab confirmation. Another guide principle is the rapid and timely access. So the stockpile, the main objective is to have the vaccine ready for shipment, always 24 hours out of 7 days. So we always receive, when we receive an outbreak request, a declaration, and then a request from the country, the vaccine must be shipped in 7 days. So this flow chart is show you the mechanism that is very simple. We have the country request when they have an epidemic. So they have to submit some information that is based on the lab confirmation and the epidemiological situation to understand the needs and how many doses they need. So then the request is is shared with the ICG members, and the ICG members must make a decision in 24 hours. If the decision is to approve, immediately the request goes to UNICEF Supply Division, who is the procurement agency of the ICG mechanism, to communicate the needs to the manufacturers and organize the shipment to the countries. So if there is a need for further information, the request go back to the country to complete the request. So all this process should take no more than 10 days. That's our goal. So as it was mentioned before, the stockpile was created in 2021, and you have the link in the slide to see all the details and how to apply as well to the stockpile if there is an emergency. So Ebola vaccine was pre-qualified in 2021, and the recommendations, as it was mentioned by Mori in the introduction, is for outbreak response, is because it's one dose vaccine, and it provides immunity very quickly in the first week. So, and full protection in 14 days. The ICG mechanism has been established with the financial support from Gavi that procure financing the vaccine and the operational cost. And there will be a presentation from Gavi to give you more details as well. As I mentioned before, if you click on the link, you will get all the information that you need to submit a request to the ICG Secretariat. It's a very simple request where you have to fill out a form and provide epidemiological data, lab confirmed data as well, the cases, and then the needs in terms of number of doses, syringes, safety boxes, and all the medical confirmation that you need to respond to an outbreak. So, and then the vaccine that is in the stockpile can also be used for preventive use, and there will be a presentation from Afro to explain you in more details why is needed the preventive vaccination in healthcare workers and frontline workers. So as I mentioned before, the ICG mechanism provides the vaccine to respond to an outbreak, and the strategy is ring vaccination. And as you can see there, you have a case, and you have to identify by contact tracing the contacts and the potential contacts of this case. And these people are prioritized for vaccination, as well as part of the potential contacts, we vaccinate the healthcare workers that are in the similar area and frontline workers that are responding to the outbreak. So as I mentioned before, the establishment of the stockpile was in 2021, and the initial amount that was decided at that time to keep in stock, it was 500,000 doses. Of course, the 500,000 doses were not in the stockpile at the first day. It was built up during the 2023. We completed from 2021 to 2022 and 23, and now we have a stockpile of 500,000 doses. And you can see in the table as well the expiry date of the doses that can be offered if are not used for the outbreak response in the first 2 years. And the shelf life of the vaccine is 3 years. And when the remaining shelf life is the 12 months, that can be offered to the countries for preventive vaccination of frontline workers and care workers. So, and here in the map, you can see the number of countries that have already approved the vaccine by their own national regulatory authorities. So the vaccine is, of course, approved in the US FDA, by the US FDA, in Europe by the EMEA, and as well as for several countries in Africa. This is the dashboard of the ICG website. So you can as well clicking on the link on the slide, you can follow all the doses distributed for outbreak response and preventive vaccination. So I think that's all. I'm just to summarize, the ICG has been very useful mechanism to prioritize the vaccine allocation during emergencies, not only for Ebola, for stockpiles as well. So any country facing an Ebola outbreak can request the vaccine, even if it's not only for the African continent, but most of the outbreak has been there. So it's available for any country that is facing an outbreak. And the stockpile of Ebola vaccine to respond to the epidemics has been a key element for preparedness and response so far. We have used the vaccine in several outbreaks in DRC following the establishment of the stockpile. And for the time being, we have had a little demand for preventive use. So this is one of the main objectives of this webinar, is to create awareness about the availability of the vaccine for preventive use. So I stop here. I'm happy to answer questions when during the Q&A chat.
Thank you, Alejandro. Thank you very much for your presentation. And once again, I would like to remind you, all the attendees, all the material for this webinar will be shared with you at the end of the session. So now, for the next 20 minutes, I would like to call Rina Doshi, working in the team of immunization at the WHO Afro. Rina, are you connected? Rina? It looks like she was having some network challenges in US side. So, Rina Doshi, can you hear us?
Hopefully you can see me now.
Yeah, now you have 20 minutes. Over to you.
All right, great. Sorry. Hi, everybody. My name's Rina Doshi, and I'm an epidemiologist focusing on immunization in emergencies. So I'm just going to talk a little bit about preventative vaccination of healthcare workers against Ebola. So just a quick recap on Ebola disease. There are 4 Ebola viruses that cause illness in people. We're really only going to talk today about Ebola virus, which is the species Zaire Ebola virus, which causes Ebola virus disease, or EVD. Just a little bit about the history. So the Ebola viruses were first discovered in 1979 in simultaneous outbreaks. One was in DRC, in a village near the Ebola River, hence the name. And another outbreak occurred in what is now South Sudan, but that was a different species, Sudan virus. The majority of outbreaks that we've seen over the last few years are caused by Zaire Ebola virus. And you can see the map, which just describes countries who have reported past outbreaks and which species they are. So just a little bit about how Ebola virus disease is transmitted. So it's there are epizootic episodes in animals. Currently, the reservoir is unknown, but it's thought that it passes on infection to other animals. And there have actually been large-scale epidemics in primates and animals in the forest, such as forest antelopes. Scientists think people are initially infected through contact with an infected animal, for example, maybe a fruit bat or non-human primate, potentially when handling dead or sick animals in the forest. And then, of course, we know that secondary transmission does occur, either through direct contact with blood, with secretions, or other body fluids of infected persons. And we know that there is a high transmission risk when we're providing direct patient care or handling dead bodies. And then finally, there is the persistence of Ebola virus in body fluids of EVD survivors, which does pose a risk for sexual transmission or breast milk transmission. This is just another diagram demonstrating human-to-human transmission. So again, spreading through direct contact with body fluids. Also belongings such as clothes, eating utensils, and mattresses can also transmit. So just to recap of the most recent outbreaks, the largest outbreak in history was in West Africa in 2014 and 2016. The second largest was in North Kivu in the DRC from 2018 to 2020. Now, there have been 5 outbreaks in DRC since 2020. The outbreaks have been linked either to a new zoonotic introduction or a persistent source of infection, such as a survivor. There was also an outbreak in Guinea in 2021, which was also suggestive of persistent source of infection. And then just to note that the most recent outbreak in 2022 in Uganda was a different species and is not currently vaccine preventable. So moving on to available vaccines. So there are actually 2 licensed and WHO pre-qualified vaccines to prevent Ebola virus disease. The first that we're going to focus on today is the 1-dose vaccine produced by Merck, marketed as Ervebo. And the second is a 2-dose regimen, which is given 56 days apart, which is marketed as Zavdeno or the MVA-BIA, and it's produced by Johnson & Johnson. And again, we're just going to focus on the one that Alejandro discussed that's available in the stockpile. So Ervebo is indicated for individuals 1 year and over. Now, the Strategic Advisory Group on Experts, known as SAGE, did recommend off-label use during an outbreak for children from birth to 17 years of age. And this is because every age group is at risk during an outbreak. Also off-label use among pregnant and lactating women. So to use the vaccine off-label, formal off-label authorization in countries is required in these subpopulations. So really the only contraindication is severe allergic reaction to any component. So it's a live attenuated recombinant virus vaccine. It stimulates an antibody response against Zaire. It does not provide protection against other species, as I mentioned previously, such as Sudan Ebola virus. And it's also really important to note the vaccine does not contain the entire Ebola virus, just a very small piece, and cannot give someone Ebola. And this is just a picture of actually how the vaccine is made. So there are a few side effects. They do usually happen within 24 hours after vaccination, and they typically get better within 1 to 2 days. Most frequently, we see a sore arm, you might feel tired, you might have a fever or a headache or muscle ache. Less common, you might feel nauseous, mild joint swelling, skin ulcers, blisters, and mouth ulcers. So vaccine efficacy, there's only one efficacy study, which was conducted in Guinea. Many of you have maybe heard about it, called Ebola Ça Suffit. It showed high efficacy, 100% with a wide confidence interval. And it provides protection about within 10 days. So it is a vaccine that can be used for outbreak response. The long-term durability for both of the vaccines is unknown. Antibody responses in studies have been maintained up to 3 years post-vaccination, and there are ongoing studies to assess the longer-term immunogenicity and also with a booster dose at 18 months and other time points. But high antibodies don't necessarily equate to protection, and so more evidence should be generated to determine when these booster doses are needed and if they are needed. So just to quickly review the SAGE recommendations. So during an outbreak, Ervebo is offered through ring vaccination, as Ale just previously discussed, because it's effective, it's dose sparing to all age groups. So that would be contacts and contacts of contacts, or your probable contacts. Those part of a ring should also receive another dose if they hadn't been previously vaccinated in the preceding 6 months. And that's really just because we don't know the duration of protection at this time. During an outbreak, preventative vaccination should be provided to at-risk individuals in neighboring areas and countries where the outbreak may spread. So that really includes healthcare workers. And then also the 2-dose regimen can be offered to some individuals who are at lower risk. of EBD. And this is really because of the 2-dose regimen that isn't really suitable for outbreak response. So we just touched on this, but just as a recap, ICG manages the provision of these emergency vaccine stockpiles and antibiotics and antivirals to any country during the outbreaks. It's made up of those 4 member agencies that Ale mentioned, and Gavi supports operational costs for eligible countries, and we'll hear from Gavi shortly on that. There's 4 stockpile vaccines. Ebola is our newest one. And as many of you may have heard, there were supply constraints between 2018 and 2021, but the stockpile was filled over multiple years. And today, as mentioned, it's at over 500,000 doses. So we know that stockpiles are used generally for outbreak response, but ICG with Gavi support has offered available vaccine in the stockpile for preventative Ebola vaccination of healthcare workers and frontline workers. So there are about 200,000 doses available in 2024. Gavi can provide funding for operational costs associated with vaccine delivery. The website is below. You'll have these slides, and the next presentation will talk a little bit more detail on this. So healthcare worker vaccination. Why do we even want to vaccinate healthcare workers? Well, it protects a vital workforce. We know that healthcare workers are the backbone of the healthcare system. They're at increased risk of VPDs, such as Ebola, influenza, because they're in close contact with patients and bodily fluids. There's also a shortage of healthcare workers in many countries, which leads to additional stress on the system. This is also really a critical element of pandemic preparedness, which I'll discuss a little bit in more detail, and can reduce the delivery time of a pandemic vaccine, which I'll show you some data on in a second. And really, as you know, Charles mentioned in his opening remarks, this is the first step toward vaccination across the life course and can improve acceptability of adult vaccination. So here's just a breakdown of healthcare workers in past EBD outbreaks. And as you can see, just looking at the healthcare worker line, that healthcare worker infections actually represented 3 to 20% of all cases in the last 7 outbreaks. So quite substantial. So we know that healthcare workers are among the first victims when treating patients. Infected healthcare workers can also perpetuate nosocomial disease transmission to our more vulnerable patients at higher risk, especially at the start of an outbreak. In West Africa, it was estimated that healthcare workers were 21 to 32 times more likely to be infected than people in the general adult population. And you can see the number of confirmed and probable healthcare worker cases, EBD cases over time, and how the proportion was quite high at the beginning. Here, looking specifically at the North Kivu outbreak, you can see the confirmed and probable cases among healthcare workers by week of onset from the date of outbreak declaration. So the red line is the date of outbreak declaration, and you can see that prior to that, there are quite a number of healthcare worker vaccination or healthcare worker cases. And this is really before the disease is identified, right, as Ebola. So it's not new that healthcare worker vaccination is important. WHO does recommend that healthcare workers be vaccinated against diseases with a higher risk of transmission within healthcare settings. So that includes routine immunization vaccines, annual vaccinations, such as seasonal influenza and COVID-19, and vaccines used in emergency or outbreak response. And many of our global strategies actually include healthcare worker vaccination. The Global Health Sector Strategy on Viral Hepatitis has a part on healthcare worker vaccination, as does the Measles and Rubella Strategic Framework. The SAGE Roadmap for COVID-19 vaccines also prioritizes healthcare workers, as does the global influenza strategy. And of course, we recommend Ebola vaccination among healthcare workers during an outbreak. So healthcare worker vaccination is cost-saving or cost-effective. If you look at the box in red, you can see in the influenza example that healthcare worker vaccination was extremely cost-saving across a number of different studies. And building delivery platforms for adults contributes to increasing pandemic preparedness and resilience. So healthcare worker vaccination promotes resilience. It reduces these shortages that are often seen when healthcare workers get sick. Vaccinated healthcare workers are more likely to be knowledgeable and more effective in communicating and improving community confidence and demand for vaccination. And building delivery platforms for adults does contribute to this improved preparedness and response for outbreak control. It's also, again, as I mentioned previously, the first step toward life course vaccination. So if you look at the graph, you can see that low and middle income countries with influenza programs prior to COVID-19, which is primarily among healthcare workers and adults, reached higher COVID-19 vaccination coverage more quickly than countries without these influenza programs. So setting up these platforms really does set us up for improved coverage should we need to deploy an outbreak quickly or a vaccine quickly. So here again, you can see that during the COVID-19 pandemic, countries with an influenza vaccination program had quicker COVID-19 vaccine deployment and also higher vaccine demand because they were already primed for this vaccination program. So as mentioned, countries can now request doses for preventative vaccination. The first step, of course, is to ensure that Ervebo has in-country regulatory approval or off-label use if desired. A short vaccination plan is needed. The goal is to prioritize high-risk areas, facilities where an EVD case are most likely to seek care, and also describe those target populations. So healthcare workers, individuals who are working in an Ebola treatment unit, laboratory technicians, potential response workers, traditional healers. If applicable, consider contacts of survivors, and we'll hear more about that later on, and also potentially moto drivers, just some examples. So to access the vaccine, countries can submit a request to the ICG Secretariat, and all of this will be provided. So now just moving on to our quick poll, just to gauge interest. So the first question we have for you is, your country interested in preventative Ebola vaccination? Would love to just hear. You can just say yes, no, or you're not sure yet. Just give it a minute. Can we put up the next poll as well at the same time?
No, one poll at a time.
Fine. We'll give it just 10 more seconds and then maybe pull up the next poll.
Yeah, I think that will be a great idea. It remains less than 1 minute.
Can you just put up the next poll? Thank you. And then, is your country potentially interested in introducing seasonal influenza vaccination for healthcare workers? We'll give 20 seconds for this one, and then we'll pull up the last poll. And then if you could just pull up the last poll on just general healthcare worker vaccination.
Okay.
Is your country interested in highlighting a general healthcare worker vaccination program? Yes, no, or you're not sure yet. And that's the last poll. And then I will leave that poll up and stop sharing my screen for the next.
Thank you, Rina. Thank you very much for your presentation. 20 minutes. Very good. So now I would like to ask Dr. Francisco Luquero from Gavi for the next 10 minutes for your presentation. Francisco, please. Thank you.
Minata, hi everyone.
Yeah. Can you just put it on presentation mode?
Yes.
Thank you. Over to you.
So thanks so much. Hi everyone, and I am Francisco Luquero. I'm a medical doctor, public health specialist, and epidemiologist, and I working at Gavi as the head of the high impact outbreaks team in the vaccine programs team. And I will be covering with my presentation a description of the support that Gavi provides for Ebola prevention and outbreak response activities. So the presentation is divided in two blocks. In the first one, I'm gonna speak a bit more about what is the Gavi approach for support for outbreak response vaccination activities. And in the second part, I will describe more in detail what can be, what is offered to countries to access vaccines and cash support. Probably many colleagues here today in the webinar know very well that Gavi, one of the main objectives of Gavi is to increase equitable access to vaccines. And we do this through support of routine immunization. And we are supporting as well new vaccine introductions in countries. This has allowed to vaccinate more than 1 billion unique children with Gavi support over the last 23 years. And as well, perhaps many of the colleagues in the webinar today know that one important goal of the current Gavi strategy is to keep increasing equity in immunization through prioritizing their support for routine introductions and increased coverage in areas that have lower vaccination coverage, where many children miss all vaccines and many remain under-immunized. And as you all know, these populations often live in urban slums, in remote communities and nomadic populations, or in communities that are affected by conflict. And these communities are as well often suffering other deprivations like lack of access to safe water, sanitation, education. And these communities are often exposed as well to new threats. We have seen in the recent years that climate change is affecting as well communities that are prone to suffer outbreaks, and cyclones have been reported more frequently in some parts, in several parts of the world. There is as well droughts. There is as well population movement that are coming from these climate-related issues, and there is as well other factors like urbanization that are increasing the risk of outbreaks caused by infectious diseases. Considering this context, Gavi remains highly committed to support countries in accessing vaccines for outbreak response. And as has been previously described by Alejandro and Rina, Gavi provides financial support to maintain 4 vaccine stockpiles through the International Coordination Group on Vaccine Provision. And we provide as well support for outbreak response through the Mrs. Rubella initiative. As you can see in the slide, the stockpiles that we maintain have a different size. For meningitis, the current size of the stockpile is 7 million doses. For yellow fever, 6 million doses. And for cholera, we aim to maintain a stockpile of a rotating stock of 5 million doses at all times. I wanted to launch a poll now because this figure has been already presented by Alejandro and Rina in prior presentation, but I would like to ask the participants if you know what is the size of the Ebola stockpile that is supported through the ICG. So perhaps colleagues, if you could launch the poll. So the possible answers are 100,000 doses, 500,000 doses, 2 million doses, or 5 million doses for the Ebola vaccine stockpile. So Aminata, I don't know if we are going to show the results of the poll.
I think we give few seconds to the participant to
Answer.
before present the result.
Thank you. Can we present the results of the poll?
Can you see them?
Not yet. Now, yeah.
Okay, now we can see them. So
Oh,
56% of the participants have indicated that the current stockpile size is 500,000 doses. However, we still have almost half of the participants that have provided other answers, so as the majority of the participants have clearly or rightly indicated, the current stockpile size for the Ebola stockpile is 500,000 doses. So as you can see, in terms of size, it's a much smaller stockpile that is intended primarily to allow countries to quickly respond to outbreaks. These outbreaks are less frequent than those that are caused by meningitis, yellow fever, and cholera, and therefore the size of the stockpile reflects this lower frequency and as well, so far, a lower need in terms of vaccines for outbreak response. I wanted to clarify with this slide the type of support that Gavi provides for the 4 stockpiles through the ICG. And this support entails primarily 3 buckets. First, we provide funding to procure vaccines and maintain the stockpiles, as well as funding for procurement of the injection devices. All countries in the world can access the stockpile. However, Gavi provides funding for the vaccines only for Gavi eligible countries. Countries that are not Gavi eligible can still access the vaccine, but they need to make a commitment of repayment or find another agency that can cover the cost of the vaccine on their behalf. This has been the case last year for several cholera outbreaks that happen in non-Gavi eligible countries. And despite this limitation, these countries were able to access the vaccine and use the vaccines in a timely manner. Gavi provides as well operational co-support, so support to the delivery of the vaccine. And we have a ceiling of 65 cents per target person per vaccination round. And this budget is made available upon submission and approval of a budget to WHO. So we channel this funding through WHO. And we provide as well support for technical assistance through WHO. There is a grant in which countries can request support to conduct outbreak investigations, to support the preparation of the ICG request, and as well as for monitoring and learning activities, for example. In terms of the mechanism, as Alejandro described, we are channeling the funding through the ICG because the ICG manage the stockpile with three principles that are key to make sure that the investment that Gavi is providing to these stockpiles has an impact. First, ensures an equitable access of the vaccines. It ensures a rapid and timely access to the vaccines. And the ICG mechanism ensures as well an independent decision-making in terms of the public health need for our response. I wanted to provide with this slide a snapshot of what are the volumes that are approved and delivered for the different vaccines. And as you can see clearly in the slide, while before 2015, most of the supply was towards responding to yellow fever and meningitis outbreaks, following the launch of the cholera stockpile in 2013, there has been a progressive increase in the demand for cholera vaccines. That in the last 3 years, since mid-2021, has served to provide support for countries that are suffering cholera outbreaks. These last 3 years, there has been a large spread of cholera disease in many countries, and there has been as well an increase in the interest from countries of using this vaccine. This has resulted in more than 100 million doses of cholera vaccine delivered to countries, 85 million for our response. So this 85 million represent more than double all the cholera vaccine that we are using the prior decade. If we look at the Ebola vaccine, as I mentioned before, the size of the stockpile is smaller, but we are making as well a much smaller use of the vaccine. Since the launch of the stockpile in February 2021, there has been 5 outbreaks reported, 4 in DRC and 1 in Guinea-Conakry. All have been rapidly contained, and we have used only just about 6,000 doses from the stockpile. Considering this low utilization from the stockpile for our response, a repurposing mechanism was established in 2022 to maximize the public health impact of these doses and use them with sufficient safe life to protect frontline workers with the ICG mechanism for preventive vaccination.
Francisco, you have
Yes.
1 minute to wrap up, please.
I have 2 minutes.
1 minute to wrap
Okay.
up.
Yeah. So the aim of Gavi is to keep improving the support that we provide for Ebola vaccination and decrease the risk of infection in frontline workers, as well as to improve the preparedness for outbreak control. I want to highlight as well that that the rollout of the preventive program will be very important to generate evidence for improve the understanding of the stability of the vaccine, the durability of the protection, the need of booster doses, as well as the possibility to mix and match the current vaccines. I'm going to go very briefly to one slide that summarizes the current support that Gavi provides for vaccination. As I mentioned before, currently we are providing vaccine support both for the emergency campaigns and the preventive campaigns, both through the ICG, without co-financing obligations. And I wanted to make clear this point. We are as well providing the operational co-support for the emergency campaigns and the preventive campaigns through WHO, and we provide TCA, target country assistance, for the response. Rina has already mentioned, some of these key programmatic aspects. I want to highlight just the timeliness as a key feature for the emergency campaigns and a clear identification of the populations to be targeted for the preventive campaigns. So, in conclusion, the Gavi strategy focuses on equity, aiming to leave no one behind with immunization, using both preventive and response approaches. We know that when Ebola outbreaks take place, the health systems are weakened, and therefore we need to protect both the populations and the ability of the health system to cope with these issues. And this involves as well the provision of routine immunization. The last point is that Gavi is highly committed to keep improving the access to Ebola vaccines in order to mitigate the threat that this disease continues to pose to many parts of the world. So thank you very much, Aminata and colleagues.
Thank you, Francisco. Thank you very much for your presentation. And now I would like to call Pierre Mhoza from USCDC, epidemiologist from USCDC, for his presentation on learning agenda, vaccination as a learning opportunity. And just after this presentation, we'll have a Q&A session for 5 minutes. So Pierre, at you.
Thank you very much, Aminata. Are you able to see my screen?
Yes, please go ahead.
Excellent. Thank you. Hello, everyone. My name is Pierre Mhoza, and I'm an infectious disease epidemiologist with the vaccine introduction team of the Global Immunization Division of the U.S. Centers for Disease Control and Prevention. And I will be discussing how preventive Ebola vaccination activities can be used as a learning opportunity. So when it comes to the Ebola vaccine doses and how they can be used, countries have two options through which the use of these vaccines can inform learning and further optimization of the vaccination program. And my colleagues have already touched on some of these aspects, but in this first option, you can see that countries may choose to vaccinate high-risk groups and monitor the implementation of the vaccination program. Of course, with an effective monitoring and evaluation framework in place, managers can monitor progress and lessons learned to improve uptake among high-risk groups, such as healthcare workers, frontline workers, however the country defines them to be. But also, Ebola survivors can also be, and their contacts can also be vaccinated, and that can be very helpful as well. And countries may, in the lower box, countries may also take advantage of the doses to conduct research activities that address some of the questions that remain unanswered, particularly with regards to the effectiveness of the vaccine, safety, immunogenicity in certain specific vaccine recipients. And of course, it is always important to conduct operations research for immunization programs to identify opportunities for optimization. So this slide will show some of the learnings that are needed to inform the Ebola vaccination program and potentially policy recommendations. I also just want to say up front that these are simply a few of the examples that have come up during the discussions around the key knowledge gaps, but there are no means a comprehensive list of the learnings that are needed. So to begin with, whereas clinical studies, clinical trials of the Ebola vaccine have helped us understand that the vaccine is highly efficacious and safe in idealized study conditions. Understanding the effectiveness or the impact of the vaccine in real world conditions remains unknown and is crucial to inform vaccine programs. So we know that for the average healthy person, the vaccine is safe and well tolerated. However, we still need to characterize the safety profile of the vaccine in certain specific populations, such as patients with compromised immune systems or pregnant mothers. With regards to the immunogenicity of the vaccine, I think Rina touched on this. We still need to learn more about how long the protection provided by the Ebola vaccine lasts for, and whether a booster dose may be needed after a certain amount of time. And of course, if we're talking about vaccination for disease prevention, ideally, we want to have a vaccine that provides long-lasting protection. As mentioned, with Ebola, there is some evidence that antibodies against Ebola virus may persist for up to 3 years after vaccination with Ervebo, but there's really a need for research to allow us to better understand how long protection against disease lasts. Now, in terms of the operations research needed, there are many questions that we still need to answer, but an example of one question that may be critical to answer in real world conditions is about understanding the impact and cost effectiveness of preventative healthcare worker vaccination in preventing Ebola transmission, particularly early during the epidemic, compared to the reactive vaccination of healthcare workers. Now, when it comes to preventative measures such as vaccination, it's always important to understand the social and behavioral factors driving vaccine acceptance, hesitancy, and demand in the target groups. And currently, we still have a limited understanding of the feasibility and acceptability of preventive vaccination against Ebola for various risk groups, including among survivors of the disease, as well as healthcare workers who take care of them. Of course, as you may all well know, listening to communities and understanding their views about the vaccine and understanding any factors that may affect uptake is very important. And therefore, there are many opportunities to conduct research that can help us understand these aspects and develop vaccination strategies that are tailored to communities and address their needs as well as their concerns. Otherwise, without paying attention to some of these questions of how communities understand and look at the vaccine, and also being proactive, we may have vaccines that are not being used and have a counterproductive situation that doesn't serve the public health mission. So these are just some of the questions or knowledge gaps that still persist, that countries have an opportunity to help fill the knowledge gaps by participating in the preventative vaccination of healthcare workers. But again, this is just a sampling and not an exhaustive list of the questions. And so, of course, with all the knowledge gaps that are around this vaccine, which is still a relatively new vaccine compared to other vaccines, there is a need to develop a formal learning agenda to guide the use of the vaccine. And so Gavi, WHO, and UNICEF have been coordinating with several other partners, including engaging with the representatives of ministries of health of countries at risk for Ebola, to develop a learning agenda for the vaccine. So the development of the learning agenda is a highly collaborative effort with multiple stakeholders ranging from international health agencies, donors, individual countries, academics, and humanitarian agencies. And these learning agenda will inform research on the use of the vaccine and how the research is prioritized and how the funding decisions for the Ebola vaccines are made. And I want also to mention that this kind of learning agenda is not unique to the Ebola vaccine. And it has in fact been developed for the cholera vaccine and the HPV human papillomavirus vaccine. So the learning agenda has been developed for these other pathogens to drive funding and research programming for their vaccines. And so lastly, the output, the desired output of the learning agenda will be a prioritized list of research questions that when we answer them, we will have informed decision-making to keep in check the devastating consequences of Ebola outbreaks. So in summary, there are many questions that we still need to learn about Ebola vaccination and preventative vaccination of healthcare workers against Ebola provides countries with an opportunity to participate in helping address these knowledge gaps. Thank you very much.
Thank you, Pierre. Thank you. So now we have some questions in the Q&R sessions, so I can go through them. We have the very first one. Rina Doshi, you want to reply? The question is, it is in French. Est-ce qu'on peut utiliser ces vaccins hors épidémie Ebola? Les vaccins qui ont été présentés dans le webinaire, est-ce qu'ils peuvent être utilisés hors épidémie Ebola? Rina Doshi?
Yeah. I'll answer in English, but thanks for the question. Thanks, Aminata. So yes, this is what we are proposing, that outside of an epidemic, you can conduct preventative vaccination of healthcare workers and other at-risk populations, such as frontline workers, outside of an epidemic, outside of an outbreak.
Thank you, Rina. And we have also a question from Abdurrahman Balde. It is in French. Alejandro Costa. Abdurrahman Balde asks, les conditions d'élimination des vaccins Ebola périmés ou endommagés ou cassés, s'il vous plaît. Is the stockpile, I am sure, how we manage them.
Thank you for the question. The vaccine that has already expired, or the vaccine that is no longer valid because it wasn't stocked at the right temperature, it must be discarded. There is a specific procedure to inactivate the vaccine first, and then it will be incinerated as other medical materials. But the first step is to, with chlorine, it needs to be inactivated.
Okay, thank you, Alejandro. Please, dear participants, raise your hand if you want to ask any questions. So we have 3 minutes. So, Amin, are you seeing any hand raised from my side? No.
Yes, 3 hands are raised, 4 hands now, 5
Okay.
hands, 6
Yeah.
hands.
Can you please give them the floor?
Yeah, they can unmute themselves. So the first one is Gaston Wamba.
Okay. Gaston Wamba?
Sorry, I didn't answer. Sorry, I think this was just a mistake.
Okay, then let's go to the next
Thank
one.
you.
The
Hello?
next is Anik Monjo.
Annick Monjo, can you hear
Oui,
us?
bonjour. Vous
Bonjour.
m'entendez?
Bien, merci. On vous entend.
Oui, ma question était de savoir par rapport au fait que les pays puissent accéder au stockpile en cas d'épidémie. Quelle est la situation pour ces stockpiles, attendu que le pays où je suis, le Gabon, est en indépendance vaccinale pour les vaccins de routine et n'est pas éligible pour Gavi, ne l'a pas été pour Covid. Donc, quelle serait la situation? Est-ce qu'il ne faut pas souhaiter en cas d'un autre type d'épidémie, choléra ou Ebola? Merci.
D'accord. Merci pour la question, Alejandro Costa.
I think Gavi can respond to the question on non-Gavi eligible countries, but in principle for our response, every country will have access to the stockpile if they have confirmed cases. So I leave the room to Gavi to answer the rest of the question.
Ok. Francisco?
Je peux répondre peut-être en français. Donc, comme Alejandro il a expliqué dans le chat, tous les pays peuvent accéder à les stockpiles. Néanmoins, Gavi il va assurer les coûts de les doses seulement pour les pays qui sont éligibles pour Gavi. Pour les pays qui ne sont pas éligibles pour le support Gavi, il va y avoir une demande de remboursement des coûts des vaccins. Évidemment, on ne veut pas entraîner des délais sur l'acheminement des vaccins sur les pays. Donc, ce qui est demandé au pays, c'est un engagement sur le remboursement des vaccins, bien des pays ou bien d'un partenaire. J'ai donné avant l'exemple de le choléra l'année dernière. Dans deux situations, ça a été la OMS qui a finalement remboursé le coût de les vaccins à la place des pays avec des fonds disponibles pour la riposte à l'urgence. Donc, bien les pays ou bien une organisation tiers doit assurer les paiements futurs de les doses. Mais j'ai vu confirmer que les fonds de Gavi vont permettre d'envoyer rapidement ce vaccin à n'importe quel pays.
D'accord, merci beaucoup pour la réponse.
We have another hand raised. Noboru Yabre. Can you activate your microphone, Noboru? Noboru Yabre?
Noboru, can you hear us? I think we can go to the Noboru.
Okay, the next is Jules Milogo.
Jules Milego, and after that, I will encourage everyone to put the question on the Q&R section.
Yeah, no, thank you very much. I just wanted to give the clarification and thank you all. I mean, those presentations were excellent. Following the presentation by Morena, I wanted just to clarify that the vaccine is now licensed for pediatric indication. I mean, well, probably something that I need to be certain information to provide to countries. I don't know if my regulatory affair colleagues are online, but I mean, it's something that we have since, I think it's July 2023. So it's not, the other information, I think, I mean, as we go, we probably, in the company, Mark, we will be, we are willing to provide any clarification, information on the vaccine or information that may not be clear to countries. I mean, so that they can directly, they can ask us or they can ask through you, and we will be happy to collaborate. Thank you.
Thank you, Jules. Thank you very much. And for those who don't know him, Jules Milogo is working at Merck. Thank you for the clarification. And I'm pretty sure Rina also have already mentioned it in her presentations. So, dear participant, I will encourage you to put all the questions in the Q&R session, please. There is an interesting question for you, Rina. Nathael Munhire, I hope I'm pronouncing it very well. Otherwise, apologies. Avant, on disait que celui qui a fait la maladie à virus Ebola était immunisé contre la maladie. Est-ce que cela reste encore valable aujourd'hui? Rina Doshi?
So is the vaccine still, is the person still considered vaccinated? Is that correct?
No, he's asking once the person has the EVD, it's considered being like immunized for life. So is it still the case?
Right, exactly. Yeah. No, I just want to make sure so others understand as well. So we mentioned earlier that we don't have data on the duration of protection. We do have immunogenicity data, which does indicate that the vaccine produces high antibodies that are long lasting past 3 years. But again, that's not a perfect marker of duration of protection. So during an outbreak, we do recommend another vaccine dose if the person has not been vaccinated in the last 6 months, but that's only during an outbreak.
Thank you, Rina. So as we mentioned here, we are talking about the preventive vaccination for healthcare workers and frontline workers in countries at high risk of Ebola. So far, some countries have been implemented these vaccinations. We have DRC, Guinea-Bissau, and Uganda. And in this order, I would like to call each of these countries to do the presentation for 10 minutes, each of them. regarding the experience. So if Dr. Nanu Yanga Mukadi from EPI DRC is online, you have 10 minutes for your presentations. Dr. Nanu? Jake, do we have Dr. Nanu still online?
Yes, Dr. Nanu is online.
Okay.
Dr. Nanu, please unmute yourself.
And share your presentation. Okay. Can you please put it in presentation mode, Dr. Nanu? And this presentation will be in French. So please, colleague, you can go to the translation part to choose between English or Portuguese. Thank you. Over to you, Dr. Nanu, for 10 minutes.
Merci pour... je peux y aller. Merci pour la parole accordée. Je suis Dr Nanu Yanga, médecin épidémiologiste au service de vaccination supplémentaire à la direction du PEV en RDC.
Excuse me, Dr. Nanu, can you please turn on your camera? We would like to see you. Perfect. Thank you. Go ahead.
Bonjour à tous. Je suis Nanu Yanga, médecin épidémiologiste au service de vaccination supplémentaire au PEV en RDC. Et je me présente devant vous pour avoir accompagné les provinces dans la vaccination préventive des personnels de première ligne au Nord Kivu et en Ituri. Nous allons partager avec vous le condensé de notre expérience Voilà. Comme plan de présentation, nous allons parler du contexte du pays, la mise en œuvre de la vaccination elle-même, les résultats obtenus, défis et contraintes, et on va terminer avec les suggestions et recommandations. Le contexte de notre pays, c'est que nous le savons tous, la RDC est un pays continent avec plus de 100 millions d'habitants. Et au total, nous avons 26 provinces et 519 zones de santé ou districts sanitaires, dont 53 sont difficilement accessibles. Et sans ignorer la vétusté de l'infrastructure routière dans mon pays. À côté de ça, nous avons la crise humanitaire qui a été annoncée au niveau 3 avec plusieurs épidémies à ce jour. L'épidémie de choléra d'une part, monkeypox, rougeole, CVD-PV. Et nous voulons signaler que nous avons travaillé pas dans des conditions faciles, tout simplement parce que durant l'année 2023, on a eu 315 zones de santé sur les 519 qui demeuraient en épidémie de rougeole. À côté de ça, nous avons les conflits armés de l'Est du pays, comme vous le savez tous, et ces conflits qui ont occasionné les déplacés internes. Et il y a ceux-là qui sont retournés de l'Ouganda, il y a des expulsés, il y a des réfugiés, et c'est dans ces conditions que nous travaillons. Alors, comment a été la mise en œuvre? La mise en œuvre, bon, nous pouvons le dire que ça a démarré depuis le mois de février avec toutes les activités que vous voyez, février 2023, les préparatifs et le lancement de la campagne, de la première campagne au Nord Kivu, c'était au mois de mai Deuxième campagne au Nord Kivu, c'était au mois de septembre. Et troisième, c'est en Ituri au mois de janvier 2024. Ici, nous voulons insister sur le fait que l'élaboration, l'approbation et la mise à disponibilité de vaccins au pays, ça s'est fait dans l'intervalle de 4 semaines, 1 mois pratiquement, même moins, parce qu'on a élaboré ou soumis la requête le 27 février et le 27 février et le 2 mars, on avait déjà l'approbation de Gavi. Donc, pratiquement 72 heures après, l'équipe ICG a validé notre requête. Et 2 semaines après, donc le 15 mars, on avait déjà le vaccin au pays. Maintenant, on a réceptionné le vaccin depuis le 15 mars, mais le lancement n'a eu lieu que le 20 mai. Le premier lancement de la campagne. On a connu beaucoup de difficultés qu'on verra peut-être plus loin. Il y avait des activités, il fallait intervenir contre la rougeole. D'ailleurs, l'activité a été intégrée. La vaccination à virus Ebola a été intégrée à la vaccination ou couplée avec la vaccination contre la rougeole. Et en juillet, nous avons soumis la deuxième, donc on a demandé la requête complémentaire parce qu'on nous avait approvisionné avec le premier tour. Et en juillet, donc le 27 juillet, on a soumis et le 22 août, on a eu le deuxième lot de vaccins le 22 août. Vous verrez que ici, ça a pris un peu de temps, tout simplement parce qu'il fallait fournir quelques éléments d'éclaircissement avec l'équipe de l'ICG. Voilà les résultats obtenus au mois de mai. Ici, j'aimerais insister sur la complétude. Pour une vaccination de 5 jours planifiée, on a une complétude jusqu'au J5 de 100%, mais il y a une zone de santé qui est la zone de Goma qui a vacciné avec une complétude de 100% jusqu'au J10. Et vous voyez les résultats obtenus pour la zone de santé de Goma. On voit bien que cette zone a obtenu 93% et toute l'antenne, c'était 46%. Donc, à Goma, on a eu 3 zones de santé. Kiroche, qui était initialement planifiée, mais au moment de la mise en œuvre, il y avait des affrontements. On n'a pas pu vacciner dans cette zone de santé. Et au total, pour la première vaccination de mai, on a obtenu 78% de couverture vaccinale. Alors, quant au sexe vacciné, on voit bien que les hommes ont été plus vaccinés que les femmes. Alors, deuxième lot de vaccination, qui est la vaccination de septembre. Voilà aussi la complétude. Ici, il y a une zone de santé qui est allée jusqu'au J9, mais on voit la particularité ici comparée à la complétude de mois de mai. Il n'y a aucune zone de santé qui est allée au-delà qui a atteint 100% dans les jours de rattrapage. Donc, tous se sont limités au J5 avec une complétude de 100%. Voilà la couverture obtenue. Toujours Goma qui est en tête avec 203%. Et l'antenne de Goma a obtenu 94% de couverture et l'antenne de Butembo, 24%, pour une couverture totale de 43% pour la province. Nous voulons comparer 2 éléments parce que quand on a vacciné, nous avions les outils habituels de transmission de nos données et juste après, on avait les tablettes pour faire la rétrosaisie de données. On voit qu'en général, ce sont les mêmes données, mais je peux dire à 60%, les données correspondent à ce qu'il y avait dans les outils, mais pour certaines zones, on a vu qu'il y a eu plus d'enregistrés sur les tablettes que dans les outils, et pour les autres, on a vu qu'il y avait, c'était l'inverse, quoi. C'est ça qui a donné le total. On voit à la fin une couverture où le nombre de vaccinés à 20 601 selon le rapportage des outils, et la rétrosaisie qui nous donne 15 576 tout simplement. La rétrosaisie était arrêtée à mi-chemin. Nous allons voir les contraintes qu'on a eues pour qu'on arrête cette rétrosaisie. Ici aussi, on constate que ce sont les hommes qui ont été les plus vaccinés comparés aux femmes. Et en rapport avec la vaccination d'Ituri, on voit que la couverture, ici, la complétude était à 100% jusqu'au J5. On avait des contraintes. Il n'y a pas eu des jours de rattrapage pour une couverture totale de la province à 66%.
Docteur
Ici aussi, on remarque que ce sont les hommes qui sont plus vaccinés que les femmes.
il vous reste 1 minute pour...
Alors, je vais profiter pour parler aussi de la vaccination de l'entourage des guéris qui est en cours. Les préparatifs sont en cours. Là, c'est à l'Équateur. Et pour un rayon de 5 ménages autour du cas guéri, et ce qui est estimé environ à 20 personnes qui seront vaccinées autour de ces cas. Alors, je passe très rapidement aux défis rencontrés. Comme vous l'avez constaté, l'adhésion était tardive à la vaccination, tout simplement parce que cela était lié aux MAPI antérieurs. Donc, quand on vaccinait en 2018, il y a eu beaucoup de MAPI. J'ai vu dans les chats, quelqu'un a réagi dans ce sens, mais la vaccination de 2023, il n'y a pas eu de MAPI graves rapportés. Alors, il y a comme autre défi la date de péremption. On nous a donné le vaccin avec la date de péremption qui était très proche, avec tout ce qu'il y a eu comme élasticité dans le processus. On a vacciné à la limite avec les doses qui périmaient donc le mois en cours de péremption de ces doses de vaccin. Il y a l'instabilité sécuritaire, nous l'avons cité. Il y a eu l'insuffisance ou mauvaise qualité des tablettes. Donc, les tablettes qu'on avait n'étaient pas de bonne qualité, ou par moment, là où il y en avait, c'était insuffisant pour qu'on fasse cette rétro-saisie. Alors, il y a l'échevauchement des activités. Bon, le reste là, c'est interne. Et il y a un élément capital, c'est la non-maîtrise du dénominateur du personnel de première ligne. Alors, comme suggestion, on a demandé, on suggère qu'on augmente le nombre de jours de prestations sur le terrain, qu'on passe de 5 jours à 10 jours, et l'approvisionnement dans le pays, qu'on nous donne le vaccin qui ont beaucoup plus de délais avant l'expiration, et appuyer la rétrosaisie de données, ce qui va nous permettre d'améliorer notre qualité de données. Et au DPS, nous avons recommandé, après cette vaccination, qu'on ait une base de données de tous les personnels de première ligne. Je dis et je vous remercie.
Merci infiniment, Dr Nanou, pour la présentation sur les données de la vaccination en République démocratique du Congo. And now I would like to ask to the representative of Guinea-Bissau for your presentation about the frontline workers and healthcare workers the country have been done. Can you please hear me and share your screen also? Cette présentation sera aussi faite en français. Chers participants, prière de vous connecter sur la transcription pour écouter la présentation en anglais ou en portugais. À vous. pour 10 minutes. Merci.
OK, merci pour l'opportunité. Bonsoir à tous. Je suis Tidiane Ganame, Data Manager au bureau pays OMS à Guinée-Bissau. Je suis là au nom de Dr Sidou Empêché pour présenter l'expérience de la Guinée-Bissau par rapport à la mise en œuvre de la vaccination préventive contre la maladie à virus Ebola. Le plan de présentation est ainsi affiché. Et pour gagner en temps, il faut dire qu'en termes d'informations géographiques et démographiques par rapport à la Guinée-Bissau, c'est un pays de l'Afrique occidentale avec une superficie d'environ 36 000 km², constitué de 88 îles et îlots et couvrant une population de 2 millions d'habitants environ. Et taux de mortalité infantile de 78 pour 1000, avec un taux de natalité de 4,5 naissances par femme. Et quant au contexte de la mise en œuvre de cette campagne de vaccination préventive, il faut dire que, vu la situation géographique du pays, qui a comme voisin la Guinée-Conakry, et la Guinée-Conakry a recensé les cas confirmés de maladie à virus Ebola et fait de la Guinée-Bissau un pays à haut risque par rapport à cette maladie. Et également, vu que surtout au niveau des îles, il y a de nombreux migrants qui y vont. C'est à ce fait que pour se protéger contre cette maladie, les grandes autorités du pays, en l'occurrence le ministère de la Santé, et avec l'appui des partenaires que sont l'OMS, l'UNICEF et Gavi, ont entrepris de réaliser une campagne de vaccination préventive contre cette maladie au profit des personnes à risque que sont les professionnels de santé, les agents de santé communautaires, les agents de la ligne de front, et surtout au niveau des ports d'entrée terrestres, maritimes et aériennes, et également les travailleurs humanitaires impliqués dans les activités de terrain. Et pour ce faire, un micro-plan a été élaboré conformément aux directives commandées par les partenaires techniques et financiers. Pour la mise en œuvre de cette vaccination, principalement 2 stratégies ont été mises en œuvre, utilisées. Et il s'agit de la stratégie fixe qui a concerné toutes les structures de santé publiques et privées et qui ont un minimum d'équipement pour mener une activité de vaccination, et notamment une chaîne de froid fonctionnelle et également les hôpitaux de référence. La stratégie avancée, quant à elle, a concerné les points d'entrée officiels qui sont les ports maritimes, terrestres et aériens qui ont été identifiés pour cette vaccination. Et également, le service de santé militaire est bien organisé et a été mis à profit pour cette vaccination, notamment pour vacciner les forces de défense et de sécurité à risque. Et l'équipe de vaccination de la clinique des Nations Unies, qui a également une expérience par rapport aux activités de vaccination lors des vaccinations COVID, a été mis à profit également pour vacciner le personnel des Nations Unies et des ONG qui sont à risque de cette maladie. Pour avoir les cibles de cette vaccination, on a utilisé un recensement, c'est-à-dire un auto-enregistrement de chaque participant à l'aide d'un formulaire Kobo Collect et également utiliser les données des ressources humaines au niveau des différents services et départements. Par rapport aux stratégies de communication et de mobilisation sociale, on a notamment utilisé des courriers électroniques, des lettres officielles qu'on a envoyées au niveau des différentes directions et chefs de services concernés. Et également utiliser les relais communautaires, qui sont les ASC, et pour atteindre les cibles au niveau des aires de santé et des différents services. Et au niveau des aires de santé, également des points focaux ont été identifiés et pour la surveillance des éventuels cas de MAPI et au niveau des directions régionales également. Et pour la pratique, les personnes qui ont été enregistrées avant la vaccination recevaient des emails personnalisés les invitant à la vaccination avec précision des lieux de poste de vaccination, des dates et les heures indiquées. Et les relais communautaires faisaient la sensibilisation et également au niveau des agences, des points focaux ont été désignés pour faciliter cela. En termes de logistique, ce qu'on a utilisé, les équipements de la chaîne de froid active et passive disponibles au niveau du programme élargi de vaccination, qui a assuré également le transport, la distribution des vaccins à tous les postes de vaccination dans les conditions optimales. Le stockage et la distribution a été assuré, comme on le disait, par l'équipe logistique du PEV. Et au niveau des aires de santé, les responsables des aires de santé étaient chargés de déployer les vaccins jusqu'au niveau des postes de vaccination identifiés. Et comme résultat, au cours de cette vaccination, il faut dire qu'il y a eu 3 jours de vaccination. Au total, 7835 personnes ont été recensées pour bénéficier de la vaccination et 5529 personnes ont été vaccinées, soit une couverture de 70,6%. Et les groupes cibles sont ainsi représentés à des proportions différentes. Et les catégories socio-professionnelles les plus qui ont enregistré les meilleures couvertures sont essentiellement les agents de santé communautaire, au niveau des travailleurs au niveau des ONG, les épidémiologistes, les travailleurs d'hygiène publique, les nutritionnistes et la police, les agents de sécurité et au niveau des gestionnaires de pharmacie. Et le maillage a concerné toutes les régions et de santé du pays pour cette vaccination. Et dans le principe, il y a eu 1846 personnes qui se sont enregistrées avant la vaccination et les 3697 se sont enregistrés pendant la vaccination et tous ont été vaccinés selon la tranche d'âge ici présentée. Et on note que la tranche d'âge la plus vaccinée est la tranche d'âge de 30 à 49 ans, avec plus d'hommes vaccinés que de femmes vaccinées au cours de cette campagne. On a également enregistré des cas de MAPI, soit 502 cas de MAPI non graves au cours de cette campagne dans toutes les régions et malheureusement 6 cas de MAPI graves, essentiellement dans 3 régions. Il faut dire qu'à ce niveau, il y a eu peut-être, on se dit qu'il y a eu sous-notification des cas de MAPI parce que dans la pratique, en réalité, les cas dépassent cela au cours des 3 jours. Comme défi majeur de cette vaccination, on peut retenir la faible sensibilisation au processus de vaccination parmi les groupes prioritaires et les difficultés par rapport à l'enregistrement et la communication des cas de MAPI, comme je disais tantôt. Et il y a également une réticence de certains techniciens de santé due au MAPI constaté chez leurs collègues déjà vaccinés. Et la sensibilisation tardive des agents de santé n'a pas permis de convaincre toutes les cibles par rapport à l'engagement pour se faire vacciner. Il y a eu également des difficultés d'accès au réseau Internet dans certaines localités du pays. Les leçons apprises au cours de cette vaccination, c'est qu'il y a eu réussite, il faut retenir que la réussite d'une activité de vaccination ciblant le personnel nécessite une sensibilisation anticipée. Et la mise en œuvre de cette campagne, avec le recensement et l'auto-enregistrement des cibles, nous a permis d'avoir une base de données bien détaillée pour le personnel d'appui et le personnel au niveau des structures de santé ainsi que le personnel des ONG, et une base de données qui peut être utilisée pour faciliter et améliorer les interventions similaires. Et la préparation et la mise en œuvre d'une telle campagne également compte beaucoup surtout en termes de logistique. Et au cours de cette campagne, on a pu également faire un monitorage journalier et une évaluation finale de la campagne qui a permis d'améliorer la mise en œuvre de cette campagne, et notamment l'atteinte des cibles et l'utilisation des nouvelles technologies dans la préparation et la mise en œuvre de la campagne a été d'un atout très important pour la qualité et également améliorer le suivi des cas de MAPI.
Monsieur Tidiane, les 10 minutes sont terminées. Pouvez-vous en 30 secondes faire le résumé des dernières?
C'est ça. Je suis pratiquement à la fin. Ça, c'est juste quelques images de la mise en œuvre. Ici, c'est lors d'un briefing pendant des acteurs pendant la formation. Et là, on a une photo durant la campagne de vaccination. Ici, on a un exemple de certificat médical et de certificat de vaccination que chaque participant, chaque personne vaccinée recevait dans son adresse courrier électronique. Merci pour votre attention.
Merci beaucoup. Merci Tidiane pour la présentation sur les données de la vaccination en Guinée-Bissau. Now, the last but not the least country to present is Uganda, and Dr. Annette, if you are online, can you please share your screen?
Yes, thank you very much. I want to share.
Pouvez-vous arrêter de présenter votre écran?
D'accord. Okay.
Merci beaucoup. Now the floor is yours, Annette.
All right, thank you very much. And thank you very much once again for giving us an opportunity to share our experience in Uganda. Are you able to see my screen?
Yes, we are.
Okay, good. So quickly, in the next 10 minutes, I will share on behalf of the Ugandan team our experience in carrying out a preventive vaccination of healthcare workers, but also at the same time, we had an opportunity to carry out ring vaccination. And the last vaccination was done last year, and that is going to be our main focus of this evening discussion, in line with the stockpile and in line with how to deal with the short shelf life vaccines. So Uganda, many of you may not be knowing it, is in East Africa, a landlocked country, but bordering DRC. And in the last speakers, I think you all heard about the several outbreaks from DRC, and Uganda, we've not been spared as far as having an importation of the Ebola virus disease into the country. So this is now a summary of the many registered outbreaks of EVD that we've had in this country. The Sudan has been the majority, and Arena, I think, mentioned this. At the moment, there is no vaccine, but the Zaire, which has a vaccine, it was an opportunity for us to carry out preventive vaccination and also the ring vaccination, which I'll highlight in the next couple of slides. Now, in Uganda, we've been hit badly by the health workers, and this picture is a memory for many of the Ugandan health workers whom we lost in the battle in Ebola in the year 2000. And at that time, 13 health workers died in Gulu, where this was a hospital director at that time, and we lost his life. And annually, in this hospital, they commemorate and remember him, which was really a big test for the adherence of IPC of our healthcare facilities. And this was an opportunity that meant that something has to be done if we are to protect the health workers. Given our experience of registering over 9 Ebola virus disease outbreaks, with the majority resulting from an importation of the border countries, and many of these we've seen that our frontline workers have been among the first victims. A health worker will get infected, then the following day, he will also go and infect his family members or close members. And secondly, we also have a high influx of refugees. Even now, we're having quite a number from DRC, from South Sudan, etc. And the borders do not have any walls. It's a transportation link. There's a lot of cross-border movement for economy, for education, for health. So it's just like one family. Even if it's DRC, it's Uganda, we basically one family. I may have my home in Uganda, but I go and work in DRC. The same applies to even the frontline health workers. We found out that. So what we did since 2018, when there was an opportunity to even use the Ebola vaccine, and I'm glad that the poll mentioned whether countries are interested. In 2018, because of the threat which was in DRC, we had to use the compassionate approach before the vaccine was even pre-qualified. So at that time, we targeted health workers in the high-risk districts, which is the graph showing. Over 13 districts were at high risk. And the figures you see, I will summarize towards the end, are basically healthcare workers. Now, in 2019, in June, we had an importation from DRC when there was an outbreak. But fortunately, we already had the vaccine in stock. We already had an opportunity to vaccinate the health workers. So now you see the first ring, which we targeted in Kasese, which borders DRC, we vaccinated over 1,000 people. This one includes contacts and contacts of contacts at that time, plus a few health workers were having a few concerns about the vaccine. Like all of us, we know many myths and misconceptions of the health workers. But you see, because there was already an opportunity for us to vaccinate the health workers, we had a chance to even encourage some of the community members to receive the vaccine. So that is now 2018, and then we continued with our plan for the 2019 health workers. Then another importation occurred. So we had 3 rings that we're also targeting around the same period of time. Now, in 2019 towards the end, now there was an opportunity, also a call in 2022, a call whether a country would be ready to receive in additional doses to offer vaccination against the frontline workers. Yes, we raised that request and we vaccinated over 12,000 health frontline workers also in 2022. Now, a very good experience, which many of us countries might experience very shortly, and given the presentation we've received, the stockpile, which is available, and there will be need to repurpose some of the doses that are about to expire. Uganda, we've had this experience last year. We brought in vaccines with a very short shelf life, about 3 to 4 months. But we had our plan and we said, let us target over 11,000 frontline workers, giving them another opportunity, those who would have missed. But we also expanded the scope of the districts that would benefit from this, but also use the same opportunity to continue detecting and reporting any AFIs and also strengthening. So this is the scope of the districts that we reached in 2023 last year. Now you see we brought in the capital city, which is in the central in the central region, capital city. In 2018, 2019, it wasn't targeted. But we had to go back to the same districts which were bordering DRC, and we also gave another opportunity to the frontline workers, because you know that several high attrition rate, new recruits, new students. We also vaccinated the student nurses because they have the clinical attachment to some of the health facilities. So 2023 is a very interesting experience that we want to share with you. We had to come up with a definition who is at risk of getting Ebola. And I think we all know about this, likely to touch bodily fluids, direct physical contact with a suspected case, or touching or cleaning the linen. So that means that even the support staff should be reached with the vaccine once you give this opportunity. But we also had to go and further and unpack which facility is at risk. Of course, the hospitals, any facility that is likely to receive any patients from our border, and then the bordering facilities, the point of entry screening, and we also included the training institutions, health training institutions in those districts. We got over 11,000 doses, and this is just to show you how many doses we received last year. Now, how did we go about this? Now, remember, this was a vaccine with a very short shelf life. We had just completed the COVID-19 vaccination, but that was still ongoing, with so many myths and misconceptions, and wanted to give this opportunity. So this time we changed the strategy. We brought on board all the district managers, district health managers. We empowered them to go and encourage their health workers to be vaccinated. So this slide is showing us that national level engagement from those border districts, the district managers, and cold chain technicians, the data managers. By the end of the day, they had to develop a micro plan.
Annette? I think we lost, she may have some issues with the connection. Annette, can you hear us? Apologize, it looks like we have internet issues there. Amin, are you able to see if she's still online?
Yeah, she's still online, but it seems like the communication is frozen. So I think she is having some internet connection issues.
Okay. Annette. So, Annette, let me try to reach out on phone if she's still there. Yeah, she was mentioning that she has some internet issues before the starting of the webinar. Apologize, dear participant. We try to solve out.
Meanwhile, maybe we can present the poll results.
You can't see the slide?
Okay.
The slide, no, but we can't hear you. We are happy to see you back.
You know, I think the network, we shifted, but quickly I'm about to. So now let me, this slide, are you seeing the slide now on the screen?
Not yet.
Summarizing that activities at the district level.
Annette,
Training.
I cannot see your slide. Can you please reshare it?
Can the person whom I shared with share the slides if possible, so that I stop?
We can.
Would that be better?
I mean, can you do that?
Yeah, if you can do that, the better, because I know we have challenges in our office,
Sure.
as far as sharing the slides.
Yeah.
And
could you please share the presentation from Uganda?
I had shared with a colleague who I don't remember, was it Arena? I can forward it to you quickly, but as I was even about to wind up the presentation.
Okay.
Yeah, so that we don't waste time.
Sure.
if you don't mind, is that okay?
Yes.
Yeah, because I know we're having a challenge in our office as far as the slides are concerned. Now, quickly,
I can share if you wish.
Sure. Please go ahead. I've not made any major changes.
Okay.
And you go to slide 14. Next. Next. There, yeah. Thank you very much. Now, this slide is no back, just one back. One more. Back. Now, this slide is summarizing the activities that are done at the district level. And the key message from this, for countries that are planning to do preventive vaccination, it is the second picture which is key. And engagement with the frontline workers. They have so many questions. If you do not answer their questions, you will not be able to vaccinate them. That is the key message from this slide. That engagement, and once you're having an engagement, and the people and the health workers have already made the decision to be vaccinated, your team should be ready to start the vaccination and have a mobile team. And don't get annoyed if a health worker is not ready to be vaccinated there and then. There's an opportunity for you to go back. And what we did in Uganda, we're not vaccinating all the health workers at health facility X at once. We are vaccinating them in phases. Reason, the AFIs, some of them cannot handle the pain. Okay, in the next 24 hours, they will not be able to work. So if you vaccinate everyone, you'll be surprised that when you go back, you find the whole facility health patients are waiting. There's no one. They're all sleeping or they're all trying to recover from the side effects, which will recover within two days. So for all of you who are planning to do that, you do that phased vaccination and give an opportunity for people to recover from any pain that may occur, but also for those who are still observing to see what will happen to the others who have been vaccinated. So the next slide. So as of now, last year in Uganda, we've utilized over 29,000 doses of Merck vaccine. And of these, 93% have been our frontline workers. And only 7% were during an outbreak mode using the ring vaccination. So next slide, please. So now, of the side effects, these are side effects. I want to alert that they are mild side effects, usually pain, a bit of diarrhea, a bit of vomiting, a bit of fever, but they improve. But once you are also carrying out a vaccination, you should be ready to handle any anaphylaxis that may occur, which is very rare. But if it occurs, it can be managed. And that is what we insisted on, having our first aid kit available. And we did not register any anaphylaxis during any loss due to anaphylaxis. We had some 2-3 cases, but they were properly managed and they were fully recovered. Next, please. So now these are some of the myths, the challenges we faced, myths and misconceptions for about Ebola, as like any new product which is coming in. And at that time, some health workers even demanding for vaccine against the Ebola Sudan species because we had registered an outbreak due to Sudan Ebola virus. And then the fear of co-administration of any other antigens. Remember, this is a life course vaccine. So yellow fever is being administered, hepatitis B vaccine is being administered, and of course the competing activities we had in the different health facilities, which will also affect the timing of some of these preemptive campaigns. So this one should be kept into consideration as we're planning to do the preventive vaccination. Next, please. So what have we learned from this one? Pre-vaccination sensitization is key, which I've already re-echoed, and a portion of staff being vaccinated is also key as you're carrying out a preventive vaccination. And in our setting, we also involving the political district leadership is key in also having a way of how they can increase the demand. Yes, we can bring in the vaccine for the frontline workers, but some of us are very stubborn. We want to see a leader that has been vaccinated, even if he's not eligible to be vaccinated But that is the win-win situation we need to incur when we're out in the field. And then continuously raising awareness, and then the lead by example. Now, remember we started in 2018. So we used some of these health workers who benefited in 2018 as champions to mobilize and re-echo the importance of this vaccination for those who are coming on board. And finally, once you start this activity, have those daily feedback meeting. Now, the last slide, next slide, is what are we recommending? The last slide. Oh, yes. This next, what we've noticed that this exercise has been successfully conducted, and some health workers, the beauty, have said that the vaccine works. And indeed, it works. There was, just quickly before I wind up, at the point of entry, some of these, there were 3 health workers who already prevented, who already been vaccinated. Accidentally, they touched a suspected EVD case. But when we tested the case, it was a positive case. Everyone panicked. We said no. These health workers were already protected. Fine, it's okay, you can observe them, but they did not develop the disease. Vis-a-vis someone who has not been protected, accidentally touches a suspected case, most cases, most likely, 90% chance that person could have already been infected. So this vaccine works, and those are some of the living examples you can use in your respective country. Now, finally, at the country level, we are trying to rethink about the target population. Now we've been focusing on the border districts. We've almost exhausted all the frontline workers. Now, if an opportunity comes, these are the discussions going on. What should we do? Should we expand now and go to the moderate, or we go to the communities? And this is the question we are throwing back to the global level. Should we now start targeting the communities staying in those high-risk districts so that they can also benefit from the preventive vaccination? Thank you very much. And this is on behalf of the Ugandan team. Over to you, Amin.
Thank you, Annette. Thank you very much for your presentation and all this experience. Thanks to the countries, DRC, Guinea-Bissau, and Uganda for sharing your experience. Now we are a bit over time, so we'll have 5 minutes for another question and answer session. So please raise your hand if you want to ask a question, or I will encourage you to put the questions in the question and answer section. So in the chat, I can see that Minister Social has the hands-on. I mean, can you please unmute Minister Social, or?
Yes, all people who had raised their hand have the ability to unmute themselves.
Okay, thank you. I mean, so Minister Social, can you hear us? Can you please ask your question in French, in English, or in Portuguese? Yes, Ministère social.
Bonjour, je suis, c'est vrai que c'est enregistré, ministère social. Désolée, c'est Madame Ender-Marie Lord, ministère de la Santé au Gabon. La première, il y a une de mes préoccupations qui a été posée par une collaboratrice depuis le Gabon. Oui, on a compris la réponse et nous disons merci beaucoup à Gavi qui commence à nous écouter parce que longtemps nous avons fait le plaidoyer pour notre pays qui est resté longtemps inéligible au vaccin Gavi. L'autre question, c'était est-ce que le Gavi, l'OMS, c'est-à-dire les partenaires financiers et techniques là, ont pensé déjà à intégrer le vaccin dans le calendrier vaccinal? C'est vrai que c'est peut-être trop tôt parce qu'on parle de vaccination tout au long de la vie. Ça, c'était la deuxième question. Et l'autre préoccupation, c'était... Oui, on parle de vacciner les personnels de santé de première ligne. Et je crois que le docteur de l'Ouganda, le présentateur de l'Ouganda vient de poser cette question. La communauté, parce que les personnels de santé de première ligne font partie de la communauté. Est-ce qu'il ne serait pas pertinent de d'abord commencer dans la communauté et avec l'appui des activités de communication, parce qu'en écoutant le docteur de l'Ouganda, je n'ai pas entendu parler des activités de communication. Comment ils ont réussi à vacciner les personnels de première ligne sans activité de communication? Le vaccin était là, était disponible, c'est vrai. Et dès qu'il y a eu l'épidémie en RDC, tout de suite, ils ont commencé à vacciner les personnels de santé de première ligne. Est-ce que tout de suite, ce personnel a accepté le vaccin sans qu'il ne soit sensibilisé? Voilà un peu les quelques préoccupations que j'avais. Merci beaucoup pour ne pas monopoliser la parole.
Merci beaucoup. Certainement que vous l'avez manqué. C'était l'une des slides sur laquelle Dr Annette a bien insisté en présentant l'expérience de l'Ouganda. Elle a insisté qu'il faut d'abord faire une mobilisation sociale et que les personnels de première ligne ont beaucoup de questions à poser.
We can't hear you, Aminata.
You can't hear me?
No, we can hear you. We can hear you.
Aminata, we can't hear you.
Okay, so some are hearing me, some are not hearing me. So should I go ahead?
We can hear you
Yes,
clearly.
please.
Okay, thank
Go
you.
ahead.
So, elle disait que la sensibilisation des travailleurs de première ligne était très importante, qu'il fallait le faire. C'est un point sur lequel elle a assez insisté. Et être en mesure de répondre à toutes leurs questions et avant de commencer la vaccination. Mais comme je l'ai dit, toutes les présentations qui ont été faites ici aujourd'hui seront partagées et vous aurez davantage d'informations en lisant les slides. Merci beaucoup au Gabon pour cette question assez pertinente et je voudrais passer la parole à Oyewale Tomori. Sorry if I not. Yes, Oyewale.
Yeah, thank you, Aminata. It's me. I'm coming from Nigeria. I want to thank all our colleagues who have made presentation. I managed to listen fully to what Annette was saying about Uganda. I think there's a very important publication that just came out from MSF. I think it was this week, which showed that people who were vaccinated before, vaccination helped reduce death by half, by 50%. Even amongst people who got the vaccine 2 to 3 days as early, 2 days before the onset of illness. So to answer the question, what we need now is not just the health workers, but also the communities in the areas that we know the problem is. How do we ensure that we have more vaccines to put out into the people, the community? I was also asking the question when Annette talked about the fact that health workers reacted, some of them did not show up the following day. And I was wondering how that really will affect the whole exercise. If health workers themselves are having this kind of adverse reaction, how severe was it? And how did it affect the vaccination exercise? Over. Thank you, Annette, and all the others for the great work you are doing.
Thank you, Oyewale. Annette, could you please?
Yes, quickly, I can I can respond. No. One of the lessons learned, the immunization group, we are fond of saying, yes, vaccines are very safe without AFIs. But we need to be clear to communicate what is expected. For the Ebola vaccine, it's not, I will not call it as serious AFI, but pain will occur. And depending on what pain, people perceive pain differently. And the commonest was a backache, headache, and of course the fever. And many of the health workers reported that. And some of them said, no, I cannot go to work, I need to sunbathe. I cannot handle. But it's not that a serious AFI, and it was already well known, but the perception of the pain. And so it was the pain, Professor, which was really a key factor, which really affected the health workers from doing work. But within 24 hours, 48 hours, they were back to duty. We did not register any serious one. Apart, as I mentioned, it's only the anaphylaxis, but within the first 30 minutes, but we are ready with our kit and we managed to address, to manage the health work and was able to go back to work. Over to you.
Thank you very much, Annette, for the answer. And thank you, Oyewale, for bringing up this publication on the case fatality among vaccinated people. It's really interesting. Thank you. So we have now Paul Mutu. and apologize if I don't pronounce it very well. Can you please unmute yourself and ask your questions? Paul? Paul, une fois, deux fois.
No,
Okay.
the question was already answered, so I don't want to duplicate my message.
Thank you very much, Paul. Thank you. So we have Abdurrahman. No, Abdurrahman is gone. Gift and Aniyom. Are you there?
For the presentation, I've learned, but I still have some concern. Like the last presenter said, in Uganda, almost all the health workers have been vaccinated. So what is the plans for the community, the at-risk community? What is the plans for it? Are there plans for vaccination for those at the community levels? Because they are really, apart from the health workers, they're also at risk. So that's my concern. Thank you.
So Gift, I'm not sure if I get the question very well. Do you asking if the vaccine is also available for the community, apart for the healthcare workers and frontline workers, or?
Yes.
Okay. Alejandro Costa, do you want to?
Yes, I can quickly answer that question. The current surge recommendations are only preventive vaccination for healthcare workers and frontline workers. This is because we don't have long-term protection data. So, but this recommendation will evolve as long as we collect more data on vaccine effectiveness and long-term efficacy data. So for the time being, it's only recommended for the highest risk groups, which is the frontline workers.
And Alejandro, if I might, just to clarify that for our response, the vaccine is available both for frontline workers and health workers and the communities that are affected by the Ebola outbreaks through the ring vaccination study. So for our response, yes, the community is as well vaccinated.
You are muted, Aminata.
Thank you, Amin. Sorry. I'm seeing that Abdurrahman is back. Abdurrahman, would you ask your questions, please? Unmute yourself and go ahead. Abdurrahman.
Hello?
No. Yeah, okay. Abdurrahman Balde, please go
Hello?
ahead. Yes, we can hear you.
Bonsoir.
Bonsoir.
Ma première question, mes deux premières questions ont été répondues, mais la dernière question qui n'est pas répondue, c'est en dehors des épidémies, quelle est la cible qu'on doit vacciner? Merci.
Rena, will you go ahead with this question? You want to know, outside epidemics, which are the target also to be vaccinated? I'm pretty sure he's talking about.
Yeah, I think he had fallen off before when Ali was talking about this, but yes, so the populations that are recommended are those who are at risk early on during an epidemic, such as healthcare workers, and those who might be working during an epidemic. So any kind of frontline workers. So you might consider folks that would be working in a treatment center, regardless of whether, you know, they're seeing patients or not. I think some countries have chosen to do folks at the border, also police, moto drivers. So different options, but you would need to justify why those folks are at risk in your country.
Thank you, Rina. I know that we have so many interesting questions to be asked. I'm really sorry, I apologize. We are running over time, dear participants. So I would like to call, there is an echo. Can you hear me now? So
Yes.
I'd like to ask to Dr. Mori Keita for the final words, please. We are 14 minutes over times. Dr. Mori Keita, are you here? Can you hear me?
Yeah, I'm here.
Yes.
Thank you so much, Aminata, for your good moderation. First and foremost, I would like to express my appreciation to all the speakers for the comprehensive presentations. My great appreciation also goes to all the participants who attended this webinar. It has been a pleasure being with all of you today, and I wanted to thank you. Thank you for your patience. I wish you a very good day and goodbye.
Thank you, Maury. So with that, we come to the end of this webinar. We are very glad that you participate. So all the material will be available on very soon. It will be shared with you. And we keep in touch. As you said that you have seen that this is a very beginning of a project. So we hope to see you very soon on the field probably. Bye-bye, everyone.
Thank you. Bye.
Thank you.
Bye.
Bye.
Bye.